Hi, my name is Dr. Mike Totola, and I'd like to welcome you to this webinar on reverse prep technique. We're going to cover the reverse prep kit and how I use it in my technique and some minimum material thicknesses and also some stuff about impressions as well. Because if you don't make a good impression of the world's best preparation, the lab cannot do anything in terms of creating a quality restoration for you. In fact, I would argue that you could do a so-so prep, but if you took an amazing impression of it, the patient would end up with a better result than if you did the world's best prep and took a so-so impression of that. But prep technique is still a big part of making sure we create enough room for our technicians so that we meet our material minimum thicknesses and that we give them some room to create a little artistry for us. So why do I need a reverse prep technique? Why did I have to spend a year coming up with this almost 15 years ago? I've been using it that long, teaching it for a long time, not only to practicing dentists, but to dental school students as well. And so I've verified and seen that it works in the hands of the experienced and in the hands of novices as well. Well, I had to come up with it because of my hands, specifically this one, the left one. This is the one that has the dexterity of a 2-month-old baby. But the problem is I'm left-handed. So that's a great joke, God, if that's what that is. But I had to find a way to be able to get above average crown and bridge results with a very average set of hands. In fact, a below average set of hands. You know, I start off all my live programs by talking about how at the University of Pacific, I was in the remedial operative program during my time at that dental school. That's right, out of about 142 students, I was one of 6 who showed up on Saturdays to do more preps because we were failing the class. We were not doing well. And it's because of these hands. It's not because I wasn't trying. It was because just of the talent in these hands or the connection between my hands and my brain and my eyes or whatever it might be. And because I also had a connection to my heart, you know, I cared enough that once I got out, I tried to do better and better preps, but it still wasn't happening. It wasn't until we started filming my dentistry that I was forced to get better. And forcing myself to get better was not just a matter of doing reps. I had been doing reps. I needed a new technique. I needed a new set of instruments. I needed something. I didn't even know if it existed for sure, but I was certainly on a search for something that would allow me to get above average results with a very average set of hands. And so that's why I was forced to come up with this technique. Now, most of you probably were not in remedial operative in your dental school classes. So the good news is you've already got a head start. You've got a better set of hands than I do. But what I'm going to show you today, I think, is a more accurate way to be able to reduce the exact amount that we need for these different monolithic materials. It's going to give our technicians room, whether it's in the gingival third or on the occlusal surface, to be able to create anatomy that looks like natural teeth, so they'll blend in the natural teeth. And if you're already doing great preps, this is going to be a faster way for you to get to that same place, because obviously I had to kind of reverse engineer how to get to that place. So if you remember as kids, there was kids who could paint, and then we had paint by numbers, where you would see number 1 was yellow and the spots with the 2 were red and the 3 were blue. Well, this is kind of like prep by numbers. That's how I see it. So I never really grew into the artist that I wanted to become per se, because even to this day, when I sit down to prep a tooth, I do prep by numbers. I don't think it matters to my patients, though, as long as I end up getting to a great result. I don't think they care if I'm Michelangelo or if I'm doing prep by numbers. As long as they have the Sistine Chapel at the end, maybe that's an extreme comparison, but as long as they have a preparation where the dental technician can make a great crown, the margins are going to be nice and smooth, so we have a very sealed crown that's going to last for a long, long time. As long as they keep that marginal area clean, we won't get recurrent decay, and we can have an aesthetic restoration that lasts for decades. So that's kind of what we're shooting for here, basically. And so that's where the original reverse prep kit came from. The original kit was very expensive. And as it grew and I added more burrs to it, they never actually added any more burrs to it. So it's kind of limited in its scope too. So a big shout out to Dental CAD Cam Shop, the sponsor of today's webinar. They are the one who contacted me and said, we will give you the burr kit of your dreams, and we will make it half the cost of what the old burr kit was. And you'll see that as we take a closer look. We'll look at the Burr kit, and then we'll also look at its use intraorally so you get an idea of how it's used on anterior teeth and on posterior teeth as well. So a few things about the reverse preparation technique as we get started. We're looking for predictable reduction through the use of depth cuts. So during my 15 years of practicing in Glidewell Laboratories, it wasn't too long before all of my patients were dental technicians. And dental technicians are the one class of patients, if you've ever worked on them before, they're the only patients who will get mad if you under-prepare their tooth. They don't get that mad if you over-prepare their tooth. In fact, they appreciate the extra room that you've given them to build the world's most gorgeous crown on their own prep. What they really can't stand is under-preparation. They want to be able to build a beautiful crown in their own mouth they can show off to their other technician friends. And if you tie one hand behind their back by under-preparing the tooth, they will come to you angrily, show it to you on the model, and ask you to re-anesthetize them and prep some more and take a new impression. It's an interesting experience. Most patients don't do that. They're all too happy to get out of the chair as soon as possible. Not so for dental technicians. And that's really where I learned that, there is such a thing as proper reduction, and it's based on whatever material we are prescribing for that tooth. So we have to be careful here. As dentists, we have a tendency to under-prepare teeth in the name of conservatism. We say, we want to do this lithium disilicate crown. And the lab tech says, well, you've only reduced 0.8 millimeters. And the minimum material thickness for lithium disilicate is 1 millimeter. And you say, I was trying to be conservative. That's not being conservative. That's just breaking the rules. Conservatism comes during the diagnostic and treatment planning. So if you want to be conservative as possible, we're going to probably diagnose a solid zirconia crown for that molar, because there we have a minimum of 0.6 millimeters, an ideal of 1 millimeter. And so at 0.8, we didn't quite get to our 1 millimeter ideal thickness for zirconia, but we're a couple of tenths above our 0.6 material minimum thickness. So that's where being conservative is. Prescribing a crown at 0.8 of a millimeter for lithium disilicate is just a mistake. It's not being conservative. It's asking the lab to make a crown that's too thin, thinner than the manufacturer wants that crown to be made at. So that's hardly being conservative. In fact, that's going the other direction, because now you have a crown that's going to be too thin and possibly break. And that's definitely not being conservative. So one of the things is you need to know how much you prep. One of the problems is most doctors who send in a lithium disilicate crown prep and it happens to be 0.8 millimeters have no idea it's 0.8 millimeters. Why is that? Well, in dentistry, we have this tendency of eyeballing how much we've reduced on a prep. And especially on molars, we close one eye and we take a mouth mirror, pull the patient's cheek back, close one eye and look back there and try to eyeball it in the back of their mouth where it's 100% humidity. It's basically raining in the back of their mouth. And we're trying to look through this rainstorm with one eye closed to see if we reduced 0.8 or was it 1 millimeter. Really, we're going to be able to see 0.2 of a millimeter like that? It's not going to happen. And so after getting yelled at for being conservative and under prepping so many crowns on dental technicians, I had to come up with a way where I actually knew how much I was reducing. Now, this was in the days before we had digital intraoral scanners, which is an easy way to be able to verify how much you reduced. But in the days before that, when everything was still a polyvinyl or polyether impression, we had to use depth cuts. But I still find the depth cuts to be very useful. For me, it's like having a GPS unit built into the tooth, or it's like having Waze, or Google Maps, whatever navigation app you use on your phone. Because once you've placed the depth cuts in the proper areas, the proper depth cuts for whatever material you prescribe in the proper areas of the tooth, and you reduce and combine them all, when you're done with the prep. It is like having a GPS map, because you just use the depth cuts and you prep as quickly as you can. And as soon as the depth cuts disappear, you know that you are done. And so it's not this matter of going around the tooth a couple more times and wondering, am I done? Do I need to go? How do I know when? I think I'm done, but am I done? You'll know when you're done. And not only that, you will be confident in knowing that you reduced the correct amount for whatever material you've prescribed, and that you won't get a call from your laboratory. Or even worse, you don't get a call from your laboratory and they still make the material at its minimum material thickness and then you have to go and adjust the occlusion, and the crown breaks on the patient within the next, 12 to 18 months, and then nobody's really happy. You're blaming the lab. The lab's fine with that. Go ahead and blame the lab in front of the patient. And they've got some culpability here because they didn't call you and say this is too thin. But dentists write laboratories checks, so lab techs are always nervous to call dentists and kind of critique their preps unless you give them explicit reminders that, please, I would love feedback about my preps and impressions. Even then, you have to ask a lot of times because laboratory technicians, for the most part, are conditioned not to bite the hand that feeds, and that's yours, paying them a monthly lab fee. And so they tend more to give praise to your preps and impressions. But you know what? They are the ones who know what dentists do the best preps and impressions. There's no doubt. And if you want to know who the best dentists who do the best preps and impressions in your community, call a couple laboratories that you use, like smaller laboratories especially, and ask the owner or the lead technician, hey, if you broke a tooth tomorrow, who would you go see to have that crown done? They will very quickly give you the names of 2 or 3 local doctors. And you'll say, why were you choosing them? Are they the cheapest? And they say, I have no idea what any of my doctors charge, to be honest, but I just see preps and impressions all day. And these 2 or 3 doctors really do it well. And so the laboratory techs are really the ones who know what's doing it well. And so one of the best things you can do is just pay a visit. If you have a local laboratory, go by there. Just say hi. Look at some of your preps. Look at some other doctors' preps. They can cover up the names if they want to, but just look and see what other dentists are doing. See where your preps kind of stand up, what you could have done better, what you did right, what the lab can do at this point to help give you the best restoration possible for the patient. It's one of the nice things about seeing more group practices is that we're not practicing alone in a bubble where we never get to see other dentist preps and impressions as much as we used to. But if you are, just go to your lab. This is part of creating a relationship with them as well, is stopping by and showing that you have enough interest. Ask them, you want to watch them polish some zirconia? Say you want to see a polished zirconia crown instead of a glazed crown. Can they show you? Are there any that they're doing? Just bring them in as part of the team. And, bringing them in as part of the team also includes, if you get a digital intraoral scanner, letting them see your anterior preps, before you decide to impress it, put the temps on and send the patient home. You can even do that with FaceTime on a phone. You can go ahead and scan it and send it to your laboratory, and you guys can have a FaceTime conversation. Patient's still in the chair. I do this in front of the patients with my technician, Cindy, because I say I'm letting the ceramic artist, Cindy, see this before we go and see if she needs me to smooth anything off. And by smooth anything off, it could be, round that incisal, that mesial incisal angle on number 9 to, could you reduce a millimeter more on tooth number 10? A millimeter doesn't sound like a lot to a patient, but the ceramic artist who's going to create these anterior crowns for them is now on a FaceTime call with me, and we're talking about the preps. And I can change whatever needs to be changed in real time, show it again to them with this FaceTime call, and then Cindy's like, boom, you're done. Let's do it. And anytime a technician tells you you're done on those anterior preps, you're going to get some great restorations back. It's only when we finish the preps and we take an impression, put the temps on, send the patient home. We've, a lot of times tied one hand again behind our technician's back and limiting what they can do because maybe we have Bucky Beaver preps. Maybe we didn't reduce enough in the gingival third so that the emergence profile isn't going to look good. So regardless, when it comes to these different materials, when it comes to creating aesthetic anterior restorations, there are absolute reduction numbers that we need to make these things happen. And that's why I still like to use a prep technique that's based on depth cuts. The second thing about the reverse prep technique, it gives you nearly perfect margin formation that is incredibly simple to do. And that's a big deal. In dental school, I was taught to break the contacts, reduce the occlusal, reduce the axial. And then at the very end, when we had this cylinder, now we were going to go and put the margin on with a chamfer burr. In my experience, that is the most difficult way to get a good margin on a preparation. Now, the top 10% of the class, they don't have a problem. They could probably take the handpiece and you could duct tape it to their foot and they could give you a great looking prep. But for the rest of us, I feel like this is definitely the most difficult way to do a margin, is to take a cylinder and try to put it on. It takes a lot of hand-eye coordination, takes a lot of patience. And it's still, even with all that, very easy to over-prep it and have the burr go too deep. So we're going to flip it on its head. And this is kind of why it's called the reverse preparation technique. We're going to prep our margin as the second step of like a 7-step process. So we're going to break contacts, put a cord in, and then we're going to prep our margin. We're going to prep it first, not last. And this is a big breakthrough for me. And I didn't come up with this on my own. I got this idea from a 1940s prosthodontic textbook from a prosthodontist. And I was looking at all the different ways to prep teeth and all kinds of different books, trying to find something that would work for my hands so I could get above average results with my below average set of hands, and tried all kinds of things that made no difference until I stumbled onto this technique. And this prosthodontist from the 1940s was doing this with a steel burr and a belt-driven handpiece. So this wasn't even anything being done in the modern era. But when I tried it, it absolutely changed my preps. And as a result, changed my life. And all of a sudden, I could prep very predictable margins that were the same thickness all the way around, very identifiable. It blew me away. I remember looking down at that first prep with my mouth mirror and kind of being shocked and handing the mouth mirror to my assistant and saying, take a look at that prep. And she looked at it and I said, what do you think? She says, I can't believe you did that. I said, you don't get to say that. I can say that about it, but you don't get to say that. You can't say you can't believe I did, but I couldn't believe I did it either, because it was the best margin I had ever done. And it wasn't through any kind of effort. It was just through using this new diamond at a different place in the technique than I had ever tried it before. And that was kind of the breakthrough. And like I said, I've taught it to many third-year dental students, going into the school, and just show them how to do it for an hour. And then they take the burr kit and they go across to their preclinical hall and they prep an anterior tooth and a posterior tooth, and they get great results as well. So it's got nothing to do with experience or talent or anything else. It's the great thing about this technique, and the burrs that it uses makes it very easy. Like, I shouldn't be able to do preps that look this good with this left hand. I mean, I just shouldn't. Not that those are the greatest preps in the world, but they're well reduced in the areas they need to be reduced with slightly subgingival margins. We're going to get a great looking crown back from our technician. Or when we look at another set of preps from the side, I struggled for so long trying to prep anterior teeth like this, especially in 3 planes. If you look, we've got our gingival third plane here, and it tilts back towards the lingual. If you've done or seen periosurgery lately on maxillary anterior teeth, you'll remember that the roots of those teeth, they tilt back at a pretty steep angle to the palatal if you haven't seen it in a long time. The facial surface appears to be straight up and down, but that's not where the roots are when you see the surgery, and that's why we need to get this reduction in this gingival third. You can see the middle third right here, this plane that is kind of parallel to the edge of the computer screen that you're watching. And here's this important one, this incisal third plane that tilts back towards the lingual again, kind of like the gingival third was. And this 3-plane reduction, especially that incisal third, this is what keeps us from having Bucky Beaver preparations. And I suffered from these for many, many years, where I would essentially prep the rest of the tooth okay, but just leave that incisal third out too far to the facial. And there's nothing that can happen but getting, Bucky Beaver crowns back from your laboratory technician, because they've just got to build on what you did. They can give you a reduction coping. It'll slide onto the tooth and you can prep the incisal third more, and that's fine. But why not be able to get it right from the get-go? And you can see on the tooth next to it, the margin that's here. You're going to see how we prep that margin. I was never able to prep margins like this, where it was the same thickness all the way around. Why is that important? Just predictability for technicians to be able to mark margins, just knowing what your margin looks like all the way around. In case there is a little spot where they can't see it, they know what it looks like. When you look at most preps that come into a dental laboratory, there's one margin on the buccal, it turns into another margin interproximally, and it turns into a third margin, usually a feather edge, on the lingual. And so in most prep techniques, or in the hands of most dentists, whatever margin they end up doing is based on how difficult it is to get to that tooth surface. And the technique I'm going to show you today makes sure that you've got the same margin on the lingual that you do on the facial, and that it's very uniform as it goes around the tooth. Same with posterior. If we're doing like PFMs with disappearing margins like we used to, today we would do a more conservative prep with a monolithic material, but I didn't used to do metal collars, so I actually had to do deep chamfers, because that's what PFM technique calls for if you're not doing a metal collar. So here is the new reverse prep kit. This just happens to be a picture of it, closed on the left, open on the right. Again, it's from Dental CAD Cam Shop, and you can see the kit at dentalcadcamshop.com and order it there too. In fact, let's go ahead and take a closer look at the reverse prep kit. So this is the new reverse prep kit. It comes from Dental CAD Cam Shop. You can find them at dentalcadcamshop.com. One thing to know about them, they are based in Germany, so these are all German burrs. And I love German diamonds. I think they're the best manufactured diamonds out there, and I love how they cut. So we're going to have 11 diamonds and 1 carbide on here. So let's take a look at the different burrs involved in the reverse prep technique. The first one's just a 56 carbide, pretty straightforward. We're going to use it to break the contacts on our preparation, and then we're going to place a double zero cord around the preparation. The second thing we're going to do is use a round diamond, and we're going to prep the margin and do our gingival third reduction at the same time. So we have an 801 burr. 801 is the round diamond shape, and it's an 021, so it's 2.1 millimeters wide at its widest point. So it's going to give us a deep chamfer margin that dental technicians absolutely love. And you'll notice that depending how conservative you want to be, you can have margin of different thicknesses. So here's an 801 018, that's 1.8 millimeters around at its widest point. We also have an 801 016, and as you might guess, 1.6 millimeters wide at its widest point. And our most conservative one that we might use for solid zirconia in the posterior, an 801 014, 1.4 millimeters wide at its widest point. And then we use that burr to half of its depth to establish our margin. We also have a football burr on the kit. This is a 379 023, so it's a non-pointed football burr. It's a convex burr, of course, and we're going to use it for like concave surfaces, such as the lingual surfaces of anterior preparations. You can also use it on the occlusal surface of a molar, for example, when doing occlusal reduction there. And then we're going to have depth cutters that are going to help us assure that we've reduced enough for our technicians so that we meet the minimum material thickness. And we also give the technician a chance to give us some great looking anatomy on our crown. Of course, with this one, this is the 0.6 millimeter depth cutter. This is our minimum material thickness for solid zirconia for a 3Y full strength 100% tetragonal zirconia. That's our minimum material thickness. We can't expect to have great anatomy on a crown like that. Here's our 1 millimeter depth cut. You'll notice it has 2 stripes on the shank. The last one had 1 stripe. So this is a 1 millimeter depth cut. This is more of an ideal thickness for full strength zirconia, and this is a minimum material thickness for lithium disilicate. And then we have our 1.5 millimeter depth cutter, which has 3 rings on it. This is an ideal thickness for lithium disilicate. And it's also really good for solid zirconia. Both solid zirconia and lithium disilicate, the thicker they get, the stronger they get. Once we have the depth cuts in place and our margins prepared, we're going to use a couple different burrs to connect all these depth cuts together and do the axial reduction. And the first one is the skinnier one, this 856 super coarse 016, 1.6 millimeters wide at its widest point. This one's really useful when we're preparing a tooth, but we're not preparing either of the adjacent teeth. This one will sneak in between those teeth and help us blend the cuts from our 56 with our facial and lingual margins from our round burr. And then most of our reduction on the facial or on the buccal and lingual in the posterior is going to be with the 856-025. Again, another super coarse burr, exactly the same shape as the other one, just a larger size. This one will fit interproximally once we've gone through with the 016 and created some space on the axial surfaces. And lastly, just like the 856-025 super coarse, we have the same burr, same size, just in a fine grit. You can tell by that red stripe. The diamond particles on here are 40 microns. And the reason we're going to use this to smooth off our margin is that this burr, the super coarse one next to it of the same size, when you use that around the margin, it leaves some chips and chunks out of the margin. It looks a little bit like a shark tooth. And while zirconia can tolerate a feather edge margin, lithium disilicate certainly can't. And technicians don't like to have a margin that looks like a shark tooth. So because of the fact that the diamond particles are so big, because this burr cuts so quickly, right on the margin of the preparation, we are going to go with our fine grit diamond and smooth everything off so that when our technician goes to design the crowns, they're not having to make it look like a shark tooth. They're not having material break when they mill it or polish it. So you don't have to smooth the entire prep. We're just going to use the 856-025F on the gingival margins to make sure those are smooth. So those are the 12 burrs that come on the reverse prep kit. Again, you can go to dentalcadcamshop.com to find this kit and more, and we'll take a closer look intraorally at how the technique works. Okay, so what is new to you that you haven't seen them before on that kit? Probably those depth cutters. We were taught to use depth cutters in dental school, but they were just a 330 burr. It's really not a depth cutter. Okay, so it's 1.5 millimeters long on the blades, but nothing stops it if you try to go too deep. And as a result, you often go too shallow so that you don't go too deep. But you can see with these depth control burrs, you can see right here, there's a shoulder on the edge of it. And so that when you push this diamond portion into the tooth, it stops on its own. You can't go too deep. So the good news is you can't go too deep. And the other bit of the good news is you tend not to go too shallow because you push it in knowing it's going to stop at the right depth. So it's got 3 different ones that are included on the reverse prep kit, a 0.6 millimeter, again, which is the minimum material thickness for solid zirconia. We're going to say this a lot today. 1 millimeter, which is the minimum material thickness for lithium disilicate, the ideal thickness, I would say, for solid zirconia. And 1.5 millimeter, the 3-ring one that you see over here on the right, that's 1.5 millimeters of reduction. That's ideal for lithium disilicate. And it's even stronger for solid zirconia. It's the hammer test strength. So if you ever saw me hit the Bruxer crown with the sledgehammer, that's at 1.5 millimeters thick. So like most dental materials, lithium disilicate and solid zirconia, they both get stronger as they get thicker. And it's true, it's always been true for most materials, they get stronger as they get thicker. When we're talking about single unit crowns, the rules change a little bit with bridges, but we're not going to worry about that today. We're just talking about single unit crowns and a single unit adjacent crowns next to each other. So this idea of using depth cuts is probably new to you, but this is the whole game when it comes to how to make sure we have beautiful anterior restorations, especially if we're just prepping, like an upper right central incisor, like tooth number 8, and we're not prepping tooth number 9. We've always said that's the hardest aesthetic challenge in dentistry. And that's true because we're trying to match one of God's crowns, a natural tooth, with something man-made. This is where we need to be spot on with our depth cuts, especially in the gingival third and especially in the incisal third, to make sure that it's not a Bucky Beaver prep. And so the depth cuts make sure that we don't have those issues. Most dentists can look at a prep and say, yeah, that looks great. I could always do that. Recreating it in the mouth is the hard part, especially when I was trying to do it artistically, where without depth cuts, I was just trying to carve it, take this prep and carve it out of a natural tooth. That is very difficult to do. And what I kind of fell into without even realizing it is that if you put depth cuts in the right places, and again, I was just placing the depth cuts so I wouldn't get yelled at by dental technicians anymore. But if you put the depth cuts in the right place and then reduce the tooth according to those depth cuts, guess what? You end up at a beautiful prep. So it had never occurred to me early on that a beautiful prep was just another way of saying a properly reduced preparation. To me, a beautiful prep was an artistic thing that was created and I would never be able to do. I didn't realize that the beauty is in the fact that it's properly reduced in the right areas and allows your technician to make something beautiful for you. It doesn't have to be an artistic endeavor. If you want it to be an artistic endeavor, that's great. Instead of using your right hand, try your left hand, or close one eye, or just use one burr, or do whatever means artistic to you. But I don't care for myself. I just want to end up at that beautiful preparation. I don't care how I get there. If I had little forms I put on the tooth and prepped it, whatever, it just needs to be efficient, needs to be predictable, and I need to end up at the same place. The other thing that's going to be new is that 801-021C burr that I showed you. Using this to prep the margin is the thing that's different for most dentists, and this is the real kind of game changer when it comes to improving your margins to something that the lab can clearly read. Dr. Gordon Christensen has said on many occasions, after walking through Glidewell and other large laboratories and seeing the impressions and the models that come in from dentists, famously said that 85% of preps that he's seen do not have the margin clearly represented 300 degrees around the preparation. And it's absolutely true. I mean, you might have some where it's represented 350 degrees, but 10 degrees, you can't see the margin because the tissue was against it, or it goes too deep and there was tissue or fluid there. So it's not like he's saying 85% you can't read the margins. Oh, no, you can. You just can't necessarily read the margins all the way around. And all it takes is one bad area on a model for the crown not to fit well against the tooth, for that to be the area where the cement washes out faster than it should, and that's where the recurrent decay starts. So it is critical that we have an easily identifiable margin, 360 degrees around the tooth, if we want this crown to last 10, 20 years, whatever our goal is, or the rest of our life, or till our kids get out of dental school, or whatever our goal might be. And this is how we do it, is by using this burr, not necessarily the 021. You saw there were smaller sizes too, to do more conservative chamfer margins, depending on what material you prescribe. But this shape, the 801, is what's important. And the other important part is that we're going to use it very early in the technique as opposed to later. Because this is the challenge with trying to prep the cylinder like we were taught in dental school and then put the margin on, is taking a burr that has no depth cut ability and not going too deep. You can see when it goes too deep, we get that little J margin, or a ski jump, it's been called before. And that is not good. And that piece of the tooth is unsupported enamel and will break very easily. And most technicians don't even seem to think that's really happening and will smooth that off. And so we need to make sure we don't get that. And so the round burr makes it so that we don't have to have that difficult margination. So let's go ahead and take a look at what the kit looks like when we use it in real life. So we're going to be prepping this tooth, this upper left central incisor. It's next to two PFMs that are splitted together. That's a little cantilever ponic there. There's an all ceramic crown right over here on this upper right lateral incisor. And then we have a natural tooth right here. So this is one of those challenges where we're prepping a single tooth. Granted, it's next to kind of two opaque, ugly PFMs over here, but it's next to this natural tooth, tooth number 8. And so it makes it a good challenge to try to make a crown that's good here. And we're going to do it out of 3Y 100% tetragonal zirconia, but that's not important. What's important is the prep technique here. So very first thing that we're doing is breaking the contacts. Again, this can just be with a 56 burr. It doesn't really matter, whatever burr you want to use. I just like a 56 burr. I don't know, 57's a little too big. 56 matches up well with the round burrs that we use, but whichever carbide burr you want to use here is fine. I guess my only warning would be Dr. Gordon Christensen, who I already mentioned. He does not like cross-cut burrs like 556 and 557 burrs, just being too aggressive and actually causing microfractures in the dentin below where you can see it. So we break the contacts, and now we're putting our first cord in. So we set the handpiece down, and this is a size 00 cord. This is an Ultra Pack cord from Ultradent. It's a hollow braided cord. This has not been soaked in any kind of medicament or hemostatic agent. This is just a plain cord. And the reason it's plain is it's going to be in the sulcus for about 45 minutes. I'll explain that in a second. That's a non-serrated cord packer. I like non-serrated cord packers. This one's from Hugh Freedy because they don't grab onto this hollow cord. I don't like when serrated cord packers kind of inadvertently grab onto one of the threads and pull the cord out. We don't want to pull this out. Once we start pushing this in, it's got to stay in or bleeding is going to start from the sulcus. And the reason this cord is in for 45 minutes is it's going to remain in during the impression process, and it's going to remain in while my assistant cements the temporary crown. And then she's going to clean the temporary cement off from around the sulcus. And then at the very end of the appointment, before we dismiss the patient, this last cord comes out, just to make sure that we don't have any temporary cement in the sulcus itself. Especially on anterior teeth, that can cause recession and angry gingival that I want to bleed at the seat. You can see we trimmed the two ends of the impression cord and the lingual. We just tucked them down so we're even. And look at this. We're going to jump in very early here and prep the gingival margin. So here we go. We're using the 801 burr. Now, because we put that first cord in, the tissue has been pulled back about a 0.5 millimeter. So that we're going to end up getting a subgingival margin, even though we're prepping this right at the gingival margin. And this burr, this round burr, just sinks right into the tooth. And the deeper it goes into the tooth, the more control you have. And even with my below average hands, I've never hit the gingiva with this burr because you have so much control. There's so much surface area of this burr in contact with the tooth. It's amazing. And so we're just tracing it around, and the shank of the burr is keeping it from going too deep. And that's it. I just prepped a almost perfect facial margin on an anterior tooth. And what was that, 8-9 seconds? I don't even know. Now you can see it kind of connects with the 56 burr cut. There's a little ski jump there still, but we haven't even got to the interproximal yet. I just want to show you what it looks like. That's a gingival third depth cut to make sure we're going to have good emergence profile, a flat facial profile on that crown, so it's going to match the natural tooth number 8 next to it. And of course, we were going for a bilayered crown technique here, even though we were going to use solid zirconia. But if you were doing something more conservative like translucent zirconia or even Emex, you could use one of those smaller round burrs to give you a chamfer that wasn't so deep. So this has been a while ago, and this is just an illustration showing what happens when you use that round burr. When it goes halfway into the tooth, you're left with a half circle. So it's a 180-degree kind of circle where you've removed some tooth structure as you go around, and we're doing it right to the gingival margin because that's been retracted apically by the cord. And so we have this half circle, a perfect half circle in the tooth. And then when we do the axial reduction later, we're going to have a perfect quarter circle there. And a perfect quarter circle is exactly what we're looking for in a chamfer margin. So again, based on whatever material you're using, you're going to place some incisal edge depth cuts. On a posterior tooth, these would be occlusal depth cuts in the cusp tips, and we'll take a look at that after we show you this anterior tooth. But we're just putting some depth cuts here based on whatever material we're using and how much we have to reduce, and based on how much your technician wants. If they want to give you a killer incisal edge, maybe you do 1.5 millimeters of reduction. If it's going to be a monolithic material that just has some coloring and some staining, you definitely don't need to prep that much. It depends if you're still doing bilayered crowns in the anterior or not. And then here's our Bucky Beaver depth cut. This was the last depth cut that I added to the technique because I knew I was having issues with these Bucky Beaver ones. And so this is going to help when the axial depth cut. This should be right at the junction of the incisal third and the middle third. In fact, initially I was placing this a little more gingival like you see in this video. Today, this depth cut would be right down here, right where the incisal depth cut stops. It would be right along here, right at the bottom of that. So instead of being here, it would be here, because that's where we're going to have our Bucky Beaver effect, is right underneath where our incisal edge reduction is. So this depth cut would be moved right down to here. It wouldn't be here. We don't want to prep it away when we prep the incisal edge, but it doesn't need to be down that far. And so we've got our gingival reduction, our axial reduction, and our incisal edge reductions. Now, people often ask about using the round burr on the lingual. You can definitely use the round burr for your margin on the lingual if you have a tall cingulum. You just need to go in and see what it looks like on that anterior tooth. For patients who have a low cingulum, we don't use the round burr here because we want to maintain the verticality of that wall. So that's kind of a judgment call. But on posterior teeth, we are always using the round burr to do our buccal margins and our lingual margins. So now that we've got all the depth cuts in place, here's where the speed of this technique really picks up, because we can just go in and start prepping everything away. So that's the 856-025 super coarse burr. And this is really good at doing our axial reduction. And we're just kind of blending that tooth structure into the margin that we did with the round burr. And now we're just going to lay the burr on its side and go in and just remove those incisal edge depth cuts. So if it's a millimeter or a millimeter and a half, however much you're reducing here, this takes just seconds to go in there and blend those incisal edge depth cuts together. You've probably done half the preparation already just by placing the depth cuts. But again, you know how much you have reduced here, so there's no question in your mind, do I need to reduce more? You don't have to look at the adjacent tooth because you place those depth cuts. So there's a lot less guessing and estimating in this technique. Now to go interproximally, we need to take the 856-016, so the same shape of burr that we were just using, but the smaller version of it, so we can go interproximally without hitting that adjacent PFM. And on the other side, we can go interproximally without hitting that virgin tooth next to it. So if we tried to take that 856-025, that larger burr we were just using, we'd have to tip it over so far to avoid the adjacent tooth, the adjacent virgin tooth, that we would create a TP preparation. It would be over tapered in the incisal third, and it would be under prepared in the gingival third. And so when you see those super over tapered preps, that comes from trying to take too large of a burr interproximally too quickly. You have to go through first with the smaller one, the 856-016, especially on anterior teeth like this, before you can take that 856.025 burr interproximally. Posterior teeth, not so much. Sometimes you can take the 856.025 and run it mesial or distally on molars without having an issue there. So I'm just going in and doing a little more. I have electric hand pieces, so I turn the water off, turn the speed down to 1,000 RPM so that we're not generating too much heat. And you can really see what you're doing here. One for the lingual reduction, you're going to want to mark this before you start the preparation with like a piece of articulating media or like Acufilm 2, something that's like 10 microns thick. See where the lower anterior tooth is hitting the lingual of the tooth that you're prepping, the maxillary anterior tooth. And wherever that blue dot is, just go ahead and put a depth cut there. If you're doing translucent zirconia, you'd probably want it to be 1 millimeter thick. If you're doing 100% tetragonal, full strength zirconia, you could use 0.6 of a millimeter. If you're doing Emax, you would want it 1 millimeter thick, maybe 1.5 millimeters thick, just based on the patient's bruxism history. Lithium disilicate is actually contraindicated in a lot of bruxism and clenching patients who have shown a lot of wear in protrusive. So you're probably going to want to stick with zirconia, but wherever that lower anterior tooth is contacting that maxillary anterior tooth you're prepping, wherever that blue dot is, just put a depth cut there. And then when you start to use this football burr to do your lingual reduction, you know that you've reduced the right amount where that tooth is hitting. Because otherwise, this is one of those areas that's very difficult to look at, to crank your head and try to look at and see if you have enough room. It's easy to see that you don't have enough room, but then you go prep the lingual more and it still looks like you don't have enough room. And it can be very frustrating. So it's nice to be able to know you have enough room by putting that depth cut there. We're essentially done with the prep at this point. We just need to smooth the margins. So I'm putting in the top cord. This is the size 2 cord. This size 2 cord fits well on top of the double zebra cord and maxillary anterior teeth on molars, upper and lower. You can't get away with this on a lower anterior tooth though. Double zebra cord fits lower anterior, but you end up with a 0 cord on top of it, maybe a 1 cord. Same thing with maxillary bicuspids where you don't have a lot of attached gingiva. Same technique, we're going to use the double 0, but probably a 0 cord or a 1 cord on top of it. The 2 cord's a pretty big cord. And the reason we're using it here is we want to get as much lateral retraction of the tissue away from the tooth as possible. It's not about the vertical retraction. The vertical retraction's great. The double 0 cord did that just so we can have a slightly subgingival restorative margin without taking a burr there. This second cord is what gives us lateral retraction of the tissue away from the tooth. This is what technicians truly crave and what they truly need to be able to accurately mark our margins. So once that 2 cord is in, let me pause this for just a second. One other thing about that 2 cord, you may have noticed that there was a blue strand in this green cord, and that is the epi strand that's in there. So this 2 cord is actually a 2E cord, again from UltraPac, from Ultradent. And it's got epinephrine in there, which I was taught in school to be very afraid of. And I remember seeing Gordon Christensen, 7 or 8 years after I was out of dental school, and he mentioned using EpiCord as his top cord. And I said, they told us not to use that. And Gordon said, well, in my, whatever it was at the time, 30 years of experience as a prosthodontist, if somebody can tolerate epinephrine in the local anesthetic injection, then they're fine with it in the cord. And if they can't tolerate it in the injection, then we don't use it in the cord. And that's been 20 years since he told me that, 25 years. And I have found that to be true as well. If somebody can handle epinephrine in the local anesthetic injection, you can use it in that top cord and they will not experience any kind of rapid heartbeat or any kind of anxiety, where the opposite is true. If they need to avoid epinephrine, like my mother-in-law, do not use the EpiCord on them. I tried it once on her just to make sure Gordon was right, and he was. And she could feel her heart starting to beat, and we got that cord out in a hurry because we didn't want to lose a babysitter, a loved one. And so got that cord out and moved on with the procedure. So so this EpiCord is going to help us stop any bleeding that's there, because our goal is to get as close to a perfect impression as possible, or an ideal impression, I guess we should say. You can't really achieve perfection. So that cord is in there. And now again with the red stripe diamond in here, it's an 856.025 red stripe diamond with the water off at 1,000 RPMs. I'm going in and just smoothing up the margin, again, to get any chips out of the margin that might be there. We want to make sure that when the lab technician blows this up on their dental screen and goes to design the margin, there's no little shark teeth looking there. So I'm just smoothing out the margin. You can do the whole prep if you really want it to look nice. It's just kind of your call, but we really need to do it at the margins. And there's our prep, properly reduced everywhere. Of course, this again was for a bi-layer prep, even though we experimented here with the solid zirconia crown. But this was back in the day when we were doing porcelain fused to zirconia, porcelain fused to metal. We have this same shape prep now. It's just a lot more conservative because we're using monolithic materials that don't need to be prepped as much as these materials needed to be prepped. And so as a result, same shape, but we can be more conservative if we want to with today's materials. I'm going to pause it here so you can see this anatomical copper cap. And this is from Coltine Whale Dent. You've probably seen copper caps before. These are anatomic because of that cutout that you can see interproximally on the mesial and the distal. Well, you can see the mesial here. And the reason for that is when they were just straight across, they would put way too much pressure on the papilla interproximally and not enough pressure on the tissue on the facial and the lingual. And so by cutting that out, we actually used to do it with scissors, and they finally started making it that way. This now puts equal pressure on the gingiva 360 degrees around the prep. Why is this important? Well, again, we're trying to do everything we can to give our dental technician the best impression possible. So we're using the 2-chord technique. The top chord's got epi in it to stop with bleeding. And now we're using this compression cap to give us even more hemostasis, some pressure hemostasis. And we've pre-moistened that. I don't know if you can tell that's wet or not. Of course, this is an endodontically treated tooth, so it's not important here. But on vital teeth, we don't want to dry them out with a piece of cotton for the next 8 minutes, because this is going to be in for 6 to 8 minutes. So the patient slides into protrusive and bites down. And I'm going to pause it again because I just want to show you when the patient is biting down here. Look at that. The pressure hemostasis that you see here is pretty incredible. So again, we've got our three-step approach, 3-prong approach with the 2 chords, top one's epi, and now we have the copper cap. And you can see how blanched everything is here. And then you look over here on the other side of the midline, and you can see we have good blood flow in the capillary bed over on the side where we don't have any of those 3 things happening. So just by having the patient bite down on this anatomic copper cap, again, we're just driving the blood out of the area temporarily. But we only need it out of the area temporarily. We just need it out of there to make our conventional impression or our digital impression. And then it can bleed all at once. I mean, this is just the one time it can't bleed, which is so ironic that in dental school, I was taught to put 1 cord in and pull it out right before we take the impression. The one time you can't have bleeding is when we were taught to create bleeding in dental school, because a single cord, whenever the last cord comes out of the sulcus, and in a 1-chord technique, the 1 cord is the last cord. When the last cord comes out, there will be blood. So in this 2-chord technique, we're about to take the top cord out, leave the bottom cord in for the impression. And like I said, my assistant doesn't take out that last cord, the double zebra cord, till the temporary cement in place, and then it does bleed. And I don't care. They can bleed then. They can bleed on the way home. I mean, it stops before they leave the office. They can bleed on the way to the office. They can bleed the whole day. They just can't bleed right before we take the impression, which is why it's so ironic that that's how we were taught in dental school to do it, was to create bleeding at the one point where it's 100% unacceptable to create bleeding. So you can see that tooth is still moist because we moistened it. Again, it's an endo tooth, and notice just as we pull that out, you can see the space. Watch, I'm going to squirt this and then I'm going to go clockwise with the tip, but you can see the material is moving counterclockwise. When you create lateral retraction between the tissue and the tooth, the material will flow in there on its own. If you don't create lateral retraction, either with cords or a diode laser, you can use the thinnest, extra thin material that you want. You can put a vibrator on the patient's head trying to get this material to go subgingival, and it doesn't. And if it does, it goes in a very thin film, and sometimes it'll just rip and stay subgingival when you go to take the impression out. Or even if it holds together, when they go to pour it or scan it, it's so unstable that it's moving back and forth as they set it on the vibrator or from the air conditioner. You want to have a thick rim of material. But if you're doing a digital impression, you just want to have a moat. You want to take the tissue and just move it laterally away from the tooth. So that the lab technician is able to see that black space between the prep and where the sulcus is. Anywhere the tissue is touching, they have to guess. Even if it looks clear, they're having to guess. And that's what the impression looks like, or it could be a digital impression. And I'm just showing this to you because in case you're curious, but that's a solid zirconia crown. This is one of our early attempts at using it in the anterior. So again, it doesn't look as good, not as translucent as the natural tooth next to it. But it looks better than the all ceramic crown here, which the gingiva is very angry at for some reason. That's always a tough one to try to figure out. These margins probably go a little farther subgingival than they should. Definitely probably looks better than these super opaque PFMs next to it. Not bad though. Flat facial profile looks decent here. Again, not as translucent as a natural tooth, and we wouldn't expect that to be. But it looks pretty darn good. It's hard to kind of argue with our early attempt at solid zirconia here, but that's not the point. The point is more about the prep technique, being able to make sure that our technicians can fabricate a crown that is the same size as the tooth next to it, literally the same size, because that's why crowns look fake. Crowns look fake, like even on a Yellowstone model, let alone a color photograph, because they're thicker on the facial aspect than the natural tooth next to it they're supposed to match. Why are they thicker? Because we as dentists have a tendency to under-reduce in the name of conservatism, but it's really in the name of being lazy and not using depth cuts, at least in my case. They're also too thick because technicians have a tendency to overbuild in the name of aesthetics to make things look pretty. And so that combination of us tending to under-reduce and technicians tending to overbuild leads to crowns that are just too thick. And it's the reason why you can take yellow study models, just walk through the streets of your town, pick 12 people, take alginates on them, pour them up, and you and your staff can sit around and look at the study models and go crown, 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 crown. On people you've never met, never seen dental photographs on, because they just don't look like regular teeth. They're too big. If they're posterior molars, they're too big buccolingually. If they're anterior crowns, they're too big facially. They have no anatomy on the lingual because there wasn't enough reduction there either. So it's obvious to us what teeth are crowns because we have a tendency to under-reduce, technicians have a tendency to overbuild, and therefore crowns tend to be bigger in some direction, facial or buccolingual, maybe incisal, but that's an easy one to catch. They tend to be bigger than the natural teeth next to them, which is why they look fake. And you can see here when you use depth cuts, even with a material that's not aesthetic, again, that's like original Bruxer, 3Y 100% tetragonal, it's not a translucent zirconia. The reason it even looks halfway decent is it's the same thickness, the same size, especially in the gingival third, as the natural tooth next to it because we reduced enough to give our technician the room to do it. So let's quickly just go through some pictures of what the reverse prep technique looks like. On a posterior tooth, you can probably already guess where it's the same steps as on the anterior, but we're gonna break the contacts on the mesial and distal with our 56 carbide. Then we're gonna place our 00 cord in place. Again, there's no medicament, no epi on this cord. It hasn't been soaked in anything. This cord is gonna retract the gingival tissue vertically about 0.5 millimeter, maybe 2/3 of a millimeter, which is fine because then we're gonna use our round burr to create our margin there so that when this 00 cord comes out and the margin rebounds, we're gonna have a slightly subgingival margin. Why do we want it slightly subgingival? Well, in an anterior tooth, we don't want the patient to be able to see where the crown stops and the tooth starts because that's hardly an aesthetic transition unless you get really lucky. In the posterior, it's probably more just practicality of, we don't want to give the patient a margin that's going to be prone to recurrent decay. So I either want my margin like 2 millimeters super gingival, like way up there, like we used to do when we were doing gold onlay or ceramic onlay preps, or I want it slightly subgingival, where we tend to have less accumulation of aerobic bacteria that are responsible for recurrent decay. Where I really don't want to have it is like equigingival, because that seems to be, in my 30 years of experience, the place where when we have margins there, that's when we really get recurrent decay, because if the patient's not hitting that well with the toothbrush a couple of times a day, that seems to be where we get the recurrent decay. So we want to have a slightly subgingival margin here, but here it's less for aesthetic purposes and more for just getting it away from the decay on somebody who's not going to clean this margin as often as they should. So the 00 cord goes into place. And next we go in, and I realize the angle is off on that illustration a little bit, but you get the idea. We're putting the round burr in and we're getting a half circle. The illustration kind of shows it being in farther than half, but it's supposed to be a half circle. And we do that on the buccal and the lingual. As I mentioned, sometimes this round burr will actually even fit mesiodistally, depending on what size you're using, depending on what the adjacent contact on the molar next to the molar you're prepping looks like. Especially with the smaller ones, the 014, the 016, you can just go all the way around the tooth with that. With the bigger ones, if you're using like the 021 as we're illustrating here, you can't take that round burr all the way through there. It ends up being connected by that 856.025. But regardless, we have done our gingival third reduction by using the round burr. Again, we're doing it right off the bat at the beginning of the prep technique. Then we're putting some depth cuts in the 4 cuss tips. If that sounds like too many and slows you down too much, just put them in the lingual cuss tips. 99% of the molars that I saw that were under-reduced in my 15 years at Glidewell, it was always the lingual cusps. 1% of the time it was the buccal cusps. So if you don't want to take the time to put 4 depth cuts in each of the cuss tips, just do mesiolingual and distolingual. But in the beginning, just do mesiobuccal and distobuccal too, and then one in the mesial pit and one in the distal pit. So it's either 6 depth cuts, or if you're kind of being lazy, 4 depth cuts if you don't do the mesiobuccal and the distobuccal cuss tip. And that's what you're kind of seeing illustrated here. We just did it all in a line so you can see all 3 of them. And then once you've done that, you're going to do the axial depth cut. So again, this is going to be at the height of contour on a posterior tooth. Remember, on the anterior tooth, it was at the junction of the anterior third and the middle third. So just gingival to where the incisal depth cut ended is where that goes. We're going to do it at the height of contour here. Again, this depth cut is based on whatever material you're using. So if this was a second molar where you had no room and little clinical crown, this could be the 0.6 depth cut. If this was a regular molar, where a first molar where you had plenty of room, this is going to be a 1 millimeter depth cut. In my hands, a 1 millimeter depth cut for a solid zirconia crown. If you like lithium disilicate, you could be doing 1.5 millimeter and then adhesively bonding the crown into place to increase the fracture toughness even more. I'm more of a, let's just cement a zirconia crown here on this molar. I love solid zirconia for molars, and I love lithium disilicate everywhere anterior to that. That's just me. But again, once we have the depth cuts in the tooth, now we're ready to go. This is like our GPS unit here. So the prep technique might seem a little slow in the beginning, and it kind of is as you're putting the depth cuts in, but once they're in here, you just rip with the 856.025. I mean, you just put it in at this angle and just go mesial distally until boom, the depth cuts are gone, and then boom, do it over on the other side. And then the same here. We already know we've reduced enough here, and we just go in the axial and get rid of that depth cut at the height of contour, and we've done it. I asked the illustrator for a sandpaper disc, and I got a Joe Dandy here. Don't use a huge metal disc here. This is supposed to be just a sandpaper disc to round off those little points that you get with most techniques, but we just don't want that for milling purposes. You know, whether it's lithium disilicate or zirconia, all the milling burrs have round tips. So if you have 90-degree pointy angles on your preps, it can't replicate that in the crown, so it has to prep around there. So it over preps, kind of a zone of safety around there, which is fine, except that, and you're just gonna have a little more cement up there. But also, if you had a material that was at its material minimum thickness right there, by over prepping past that sharp angle, it now might be too thin, and you might have a crown that's prone to fracture. So just round off all the angles. It's just, whether it's being milled or pressed, it's just a better way to do it. Here's our 2E cord. Of course, this should be a blue cord with a green strand in it if it's the epi cord, but it's easier to see when it's just green. So at the end of the prep, that's going to go on top of the 00 cord, just like that. And now we have the lateral retraction of our tissue away from the tooth. Again, this bottom cord is going to stay in place during the impression. We're going to put our anatomical comfort cap on. Patient's going to bite down, boom. So again, our 3-prong approach to great impressions. We're going to wait 6 to 8 minutes. How did we come up with 6 to 8 minutes? We tried 2 to 4 minutes. It didn't seem like enough. We tried 10 to 12, and it didn't seem like any more. So 6 to 8, however long it takes to do a hygiene check, okay? Go do a hygiene check, come back, and then take this off. Again, we want this moistened, this comfort cap, especially if the tooth is vital. We're not trying to dry out the tooth with our super sponge and make it more sensitive. So we want this moist. This is not about drying off the tooth. This is strictly here to put pressure on the gingival tissues around here to help dry blood out of the capillary bed, and frankly, to keep the patient from playing with the prep, or the cord, the loose end of the 2 cord that's hanging out with their tongue or anything. So the reverse prep technique works fantastic when you're prepping a crown for the first time. It ensures that you have enough reduction in the right places and that you have the best margin you can get with the least amount of effort. But a lot of the dentistry we do is taking off old crowns and replacing it with a new crown because of recurrent decay or maybe a fracture, we don't know how much the previous dentist reduced. I've tried several different methods over the years. Bite registration, wax, bite registration with calipers, trying to figure out how much reduction I had. I haven't found anything easier than these PrepSure guides from Contact Easy. You can see they come in 3 dimensions. There's a 1 millimeter, a 1.5, and a 2. I really keep begging them to come out with a 0.6 for minimally reduced solid zirconia crowns on second molars. Hopefully one day they will. You can see there's a mesial end and a distal end. There's no faster way to be able to check reduction. So here you can see the mesial end being used, and you can have the patient open and set this on the occlusal surface of the teeth and then have them bite together. Or you can just have them bite together, make sure they're in maximum intercuspation, and then slide this in. If you have enough buccal reduction, it'll slide right in. So the mesial end of this is checking the mesial marginal ridge to make sure there's enough reduction. If you can pull this out towards the facial, then the buccal cusps are reduced enough. If the patient can bite all the way together and these teeth are touching in maximum intercuspation, then you've reduced enough on the mesial half of the occlusal surface. And then if you can push that through to the lingual, your lingual cusps are reduced enough. And then all you do is flip the instrument around with the distal end, slide it in, check to make sure your distal buccal cusp is reduced enough. If the patient is closed when you're on the occlusal surface, the distal marginal ridge and the distal half of the occlusal surface are reduced enough. And then just slide this out to the lingual. And if it slides out to the lingual cusp is reduced enough. If you go to slide it out to the lingual and you hit tooth structure or the patient's teeth pop apart, then you need to go in and adjust the distal lingual cusp more. If you have a digital intraoral scanner, you can just scan the prep, scan the opposing tooth, and it'll show you the reduction. But if you're still taking conventional polyvinyl and polyether impressions, which is fine, they both still work great. Most of the great dentistry for the last 40 years have been done with these materials. Don't think they don't work anymore, they do. But you don't get the benefit of being able to visually see how much you've reduced on the tooth. And that's where these PrepSure guides come in really well, because you're not having to squirt material in and then try to read it with a caliper or hold a wax up to a light. You're just going in with an instrument and seeing if it passes freely. Even the flexible clearance tabs, I tried those for a while, but they're not dead soft enough. And they give you false positives. Like you've definitely reduced a millimeter and you put the millimeter one in, the patient can't close all the way because it needs to go up over the buccal cusp, into the occlusal groove, up over the lingual cusp, and then out again. And they're just not soft enough. So I haven't found a better way than with these Crown Prep guides to be able to do it. So one more time, I want to hit on the reduction amounts so that you carry that away from this webinar as well. Is that for just says Bruxer here, but this is for all 3Y, class 5, 100% tetragonal, yttria stabilized, polycrystal zirconia, however you want to refer to it. It's a bunch of different ways. Full strength or the original zirconias, the minimum occlusal reduction 0.6 millimeters. But if you only do that and you need to adjust the opposing, if the bite is high, because if you take these materials, they're super strong, but you take them thinner than 0.6, they will break. It's not a question of if, it's just when. So you want to make sure they're definitely 0.6 millimeters thick. Ideal reduction is 1 millimeter. If you want to be able to hit it with a hammer into a piece of plywood and not have it break, that's 1.5 millimeters. That does not simulate any real clinical situation. It's just fun to watch and fun to think about, ooh, this is going to be strong. Lithium disilicates such as IPS Emax, minimum occlusal reduction is 1 millimeter. That's the depth cutter with the 2 stripes on it. Again, at 1 millimeter, your lab should be putting a sticker on the box telling you that this crown, this Emax crown, is at its minimum material thickness. And if you need to adjust the occlusion, it's got to be on the opposing arch. Because again, you take Emax or any lithium disilicate thinner than 1 millimeter, it will break. Question's not if, it's simply when. The ideal reduction for it is 1.5 millimeters. If you're using it on molars, you definitely want it adhesively bonded versus just cement it like you can with zirconia, because it does increase the fracture toughness of the material in the mouth. And of course, Emax is even stronger at 2 millimeters because both these materials get stronger as they get thicker. And a few words about impressions. This is from my mentor, Bill Strupp, Clearwater, Florida. He says, in reality, a crown and bridge impression is merely a reflection of the dentist's integrity, nothing more and nothing less. And first time I saw that, I was like, wow, that's really harsh. But I wasn't taking very good impressions at the time, definitely below average impressions. And I was like, wow, you can't judge somebody based just on that. And I still don't know that you can judge somebody on a crown and bridge impression, but you certainly can on 10. crown and bridge impressions, because if you just happen to see one dentist, one impression, it might have been that super uncooperative patient whose buccal fat pad looked more like a buccal fat mattress and it was a queen size mattress, and you just can't get back there and work, or somebody who gags, pre-gags before you even get in their mouth. So the two-chord technique for me has always been a way for me to have lots of integrity with my impressions, because it doesn't take any skill. That's what I love about two-chord. It takes all the skill out of it. And so again, we're using that double zero chord. It's always our bottom chord. We're using the two chord, the 2E version of it, the one on the right, for maxillary anteriors and all molars. We're using the double zero with either the 0 or the 1, just based on it looks like how much attached tissue we have and what the pocket depth looks like around lower anteriors and maxillary bicuspids. Just be safe. But the two chord technique, you could put double zero on top of double zero if you didn't have enough room, and still create some amount of lateral retraction of the tissue away from the tooth, which is what's important. That's a close-up illustration of the hollow braided cord. So even if the cord looks big coming out of the bottle, it collapses as you pack it down in, and then as the crevicular fluids get into it, it kind of expands again. And so rather than working with a hollow cord where you can do more damage putting in larger cords with these hollow ones, that doesn't happen. This is just a couple of preps where the two chord has been teased out of the sulcus. And again, you can see the double zero chord in the base of the sulcus here. You can see exactly where the margin ends. You can see some unprepared tooth structure apical to that margin. And you can see this moat where the tissue has been moved laterally away from here. There's no way to miss this impression. This is going to be an amazing digital scan as well, because here's where the tooth stops. Here's this black void. Well, it's a cord, but it'd be black anyway. And then here's the gingiva. So easy for the technician to go in and mark that margin perfectly. Or whether it's a polyvinyl or polyether impression, same thing. The only way to do this really is with two chord or a diode laser. And you can do it with a diode laser too. I love diode lasers in the posterior. Don't like them in the anteriors because we tend to lose vertical height when we lose them. You can't miss this impression. You could mix alginate in a bowl with the spatula and just fling it at these preps, and it would probably still go in there. But dentists there's this fascination right now with not using retraction cord to take great impressions, and it just doesn't work. And why would it work? It didn't work 30 years ago. It doesn't work now. We either have to use something physical like cord to move the tissue laterally away from the tooth, or we need to go with the diode laser and trough around there and remove that tissue. And we know it'll grow back in 2 to 3 days, but we need to temporarily remove it or retract it to get the impression. This whole movement towards no cord is just, you can see it in the laboratory technician faces, the disappointment, and it's not a good look for us as dentists. I mean, look how easy it is. You can't miss these impressions just squirting it on there. And you can't miss this digitally either, because you've got that space in between them. And you can just tell when you look at these and you see that extra material, or when you see that moat, that open sulcus around there, you just know these are going to turn out great, whether they're digital or whether they're conventional impressions. And if you don't want a pack cord, that's fine on something like this, but you've got to use a diode laser. And that's when I'll use, some sort of material that's supposed to be a cord replacement material, but it's not, because it doesn't have any body, but they are good. As a hemostatic agent. This one's got aluminum chloride. It'll stop the bleeding, so you rinse it all out. It's hard to rinse out, so some little extra over here. But again, you can see with the diode laser, you can see kind of this onion skin look on the tissue that you get from that. But we've created that trough again. We're going to get a perfect impression there. We don't have, there are things that could go wrong if the tooth is wet or we leave some sort of moisture in the sulcus, but just dry it out. Listen, you've done everything here to be able to give yourself a great result. If you have a super gingival margin like over here, don't need to do anything on the tissue. Why would you do that with a super gingival margin? It's just where we're going slightly subgingival with our margin. And so we can get a great impression with a cordless technique. We just need to do it with a diode laser or an electrosurge for that matter. But there's just no free lunch. You can't get the impression material. The tissue